Good afternoon, and welcome to today's program titled The FCA and Commercial Insurance Claims in Private Equity Healthcare Transactions. At this time, all participants are in a listen-only mode. For those of you who are logged into the web presentation, you are encouraged to submit questions throughout the conference by typing them into the text box on your screen. For those interested in obtaining CLE credits for today's webinar, an attendance verification code will be read during the presentation that will be required on the CLE attendance affirmation form. Please write this code down. It will not be reread, and it is required for the CLE credit. Copies of the webinar recording and materials will be distributed to attendees in the days following the webinar. And at this time, I would like to turn it over to our speaker, Leon Rodriguez.
Okay, thank you very much. Good afternoon. My name is Leon Rodriguez. I will be one of your speakers and your moderator this afternoon. I'm a partner in the Washington, D.C. office of Seyfarth Shaw, and I am joined today by two of my other D.C. office-based partners, Bill Eck and John Shire, as well as our special guest, Ty Choitlar, who is the founder of the Private Compliance Group, Incorporated. And I want to tell you a little bit about each of our speakers today. Ty is the founder of the Private Compliance Group, where he works on the successful application of providing a private level of service in healthcare compliance. He brings proven abilities to facilitate and communicate compliance strategies with successful results. His specific areas of background and qualifications include certified professional coder, physician and qualified witness, federal regulatory experience, tribal healthcare experience, healthcare compliance speaker, board member in both public and private firms, and a philanthropic board member. I'm also joined by my partner, John Shire, who is in our corporate department and who represents public and private companies in buy-side and sell-side mergers and acquisitions, joint ventures, commercial contracts, private capital transactions, and impact investments. He has a deep understanding of federal and state healthcare regulations governing reimbursement, fraud and abuse, compliance and enforcement matters. John has led several of the most recognized transactions in the U.S. healthcare arena. And also from our corporate group is Bill Eck. Bill's experience in the healthcare industry ranges from mergers and acquisitions to sales and strategic affiliations. He has handled more than 30 purchase and sale transactions for hospitals, long-term care facilities, and other healthcare provider clients. He has represented syndication sponsors of ambulatory surgical centers, imaging centers, sleep centers, and other kinds of providers, as well as health systems and practice management companies and acquisitions of physician practices, including those specializing in primary care, emergency medicine, neonatal intensive care, radiology, and pathology. In the area of healthcare regulation and compliance, Bill has served as outside regulatory counsel in numerous public company transactions, offering counsel on such areas as Stark, anti-kickback, licensure, HIPAA, and privacy. And finally, I'm Leon Rodriguez. I'm a partner in the Labor and Employment Department here at Seyfarth. I'm also the managing partner of the Washington, D.C. office. I served as a healthcare fraud assistant U.S. attorney and also as the director of the Department of Health and Human Services Office for Civil Rights, which, among other things, administers the healthcare privacy laws. So today we're going to talk about the impact of False Claims Act and commercial insurance issues in private equity deals. And to go quickly through our syllabus for the day, we're going to have a quick introduction to the False Claims Act. We'll discuss its impact on private equity deals, the methodology for conducting a proper reimbursement analysis during the course of private equity transaction due diligence, remedial measures that might need to be taken as a result, And then given the times that we're in, we're going to have a short note on the False Claims Act and its potential impact in the wake of COVID-19 stimulus legislation. And we will be sure to leave just enough time to take your questions at the end of the call. So let's talk real quick about the False Claims Act. The False Claims Act, I don't imagine, is entirely new to any of our listeners or callers today. It is a civil enforcement statute at the federal level, although I would note that there are comparable statutes in many states and even in some cities. And it applies to any entity or person who knowingly presents or causes to be presented a false or fraudulent claim for payment or approval to the United States government, or as the case might be if we're talking about a state False Claims Act, a state agency. The False Claims Act has been applied extensively and has resulted in massive economic recoveries to the federal government for decades now, very much in the area of healthcare reimbursement, defense contracting, and other federal contracting. Among the things that make the False Claims Act particularly risky for organizations that may become subject to an investigation or to some other enforcement action is its penalty structure. Each individual claim found to have been fraudulent can be subject to a penalty, rather a fine, of between $5,000 and $10,000 per claim, in addition to treble damages. In other words, 3 times damages for each individual violation. Additionally, the False Claims Act has certain whistleblower provisions which enable private parties to sue, sitting in the shoes of the government, organizations claimed to have violated the False Claims Act, and thereby receive a significant portion of the recovery in those cases. Those whistleblowers can be employees. They in some instances, can be business partners. Any number of individuals can sit in the shoes of a whistleblower. Typically, when a False Claims Act suit is filed by a whistleblower, the government will make a decision as to whether to participate in the case, and the participants in that investigation could be the Department of Justice, the FBI, and importantly, the Department of Health and Human Services Office of the Inspector General. Another of the factors that makes the False Claims Act particularly risky is what's called the implied certification theory, which basically holds that any representation made in the course of obtaining reimbursement from the federal government can potentially be considered as fraudulent. Or if an entity makes a representation that it is generally following the law, which is generally a requirement when filing claims with the federal government, if the law violated is material to the payment for the particular service reimbursed, that too can lead to a False Claims Act finding under the implied certification theory. So plenty of risk to go around here. We'll also talk a little bit about private insurance risk later. But let's now start talking in detail about the typical investment and acquisition process. And what I will do now is turn over to John to talk about that process.
Thank you, Leon, and welcome everybody. Our goal today is to talk about a few things that will hopefully help you avoid ever having the FCA enter into any conversation on a post-investment or post-acquisition basis. And one of the things we want to talk about a little bit is what is your typical investment and acquisition process, and how can this lead to trouble down the road? So in a typical acquisition or investment, you are typically having due diligence run on assets and liabilities, as well as profits and loss statements. Perhaps you're going to explore some employee issues, and perhaps you're going to explore some litigation. But what is often left off the table is the actual reimbursement analysis. In other words, what is the documentation historically trailing back for, we like to look at least 5 to 7 years, as well as the claims data analysis trailing back, again, 5 to 7 years. And so the value assessment, which goes beyond exploring the typical profits and loss and cash statements, the organizational structure, assessment of the management team, is really the historical data. And so the goal here is to track the money, follow the paper trail, and make sure you have a really good picture of what the historical data looks like. The reason we're talking about this is because there are instances where private equity firms move very quickly and forcefully into industries, and they don't quite necessarily understand how the transactions can marry up to various federal regulations and corollary state regulations. I also want to mention at this point that the idea that this is segregated from commercial claims is really just a myth. The exploration into similar statutes and regulations enables the government to use data provided by the commercial providers. So to the extent that they are conducting audits or recruitment reviews, you can still be subject to exposure even when you're looking at commercial business only. Next slide, please.
Okay, now we're going to ask Bill to talk about why diligence matters and why diligence focused on healthcare and insurance claims is critical in that process.
Okay, thank you, Leon. We conduct standard healthcare compliance due diligence in all of our healthcare transactions. And this is simply because healthcare laws and regulations provide severe penalties for noncompliance. So we might begin by reviewing the target's compliance plans, complaints under those plans, and the resolution of those complaints. With respect to particular issues, the Stark Law, for example, prohibits certain physician referrals, so we would review contracts with physicians and payments under those contracts and payments made to physicians generally. The anti-kickback statute prohibits payments for referrals, so in addition to physician contracts, we would review contracts and payments with other providers. A good example of this would be reviewing contracts between nursing homes and therapy providers and leases between those types of providers. We review privacy and security compliance policies, audits, and complaints. In hospital acquisitions, we review ER access to care policies and complaints. And we always review licensure surveys and corrections of deficiencies noted in the surveys. Now, why does this matter? There's a couple reasons. It matters, one, for successor liability. Depending on the transaction structure, there's going to be a potential for successor liability. It's always present in stock purchases and mergers. However, even in asset purchases, under some circumstances, there's a potential for successor liability. And more than that, there's an exposure for continuing practices. This is a situation of once you've bought it, it's yours. So if practices that are problematic are not corrected before the closing and continue after the closing, they will create exposure for the buyer after the closing. And this is true both of False Claims Act risk and also of general compliance risk. But today, what we really wanted to focus on is claims and reimbursement diligence, and it centers around three areas. One is overpayment risk. In successor liability situations, there's a risk that a payer will go after the buyer for payments made to the seller before the closing. Claims and reimbursement diligence also provides visibility into going forward EBITDA and earnings. And claims and reimbursement diligence can also reduce FCA risk. As Leon pointed out, the Supreme Court has approved implied certification theory so that one submitting a claim to the government is impliedly certifying that the claim meets the requirements for payment. If claim practices have problems before closing, those problems need to be identified and corrected, or else the problems will infect the claim after the closing. And with that, Leon?
Thank you. So now, as I think we mentioned before, our special guest, Ty Troitlar, has provided compliance counseling in this area for many years. And as Bill and John both have seen a number of examples of where this can have significant impact on a transaction. So Ty, we're going to invite you to talk about some of those examples.
Very good. This is Dr. Troitlar, and to begin, engagements of this type really should only be written under attorney-client privilege with somebody like myself. This is the only this is the only type of way that I will enter into this type of engagement. I'm about to give you the top 5 examples of reasons for invalidating claims that I personally audited from 2015 through 2019. They come from many different styles of practices, hospitals, and taxonomies. The first is the inability to produce specific documentation, which in an electronic world, there should be no excuse. Now, if you can't produce the documentation, you just invalidated the claim. What's interesting is that some practices and hospitals might not be able to provide any documentation, but sometimes it may be just around 1 or 2 codes, at which time we can zero in a little closer and discover what is the cause. In one particular case, I had a nurse who would only use that call or only use that code. She's the only one who did it, and she was the wife of the practice owner, and she received the revenue directly. That was a bit of a problem. Next one, number 2, signatures. Signatures, to be clear, must be on the documentation, even electronically. If a document's not electronically signed, it is not going to be able to be supported. And it goes beyond just having a signature. The signature of the provider must be present. The signature could be present, but it might not be the provider. It could have been somebody else who signed it. That's a problem. The provider's signature is present, but the procedure needs to be countersigned by a supervising physician. Now, that's a real interesting issue that's come up quite a bit across the country over the last few years with something called Incident 2, which would require an entire afternoon to try to explain. Without the evidence of the supervising physician, that claim cannot be supported at all. Occasionally, we have in signatures what I call an abundance of signatures. So I have multiple electronic signatures. Everything is correct. Everything's great. But the physician in question happens to be at 4 different practices across 200 to 300 miles, all at the same time. This is an issue. This is a real problem when you're looking at the signatures. So it's not just a glance. Sometimes we have, number 3, lack of documentation. Documentation is not there to support the diagnosis. We don't have the documentation to support the diagnosis, and we don't have medical necessity. Medical necessity is vital in order to provide the procedure. The procedure itself needs to be documented, and part of the provider's knowledge and abilities needs to be on that page as to why it was provided. And there also has to be some specific information depending on what procedure was done. Sometimes it's the amount of time, the temperature, radiation exposure, whatever it is, has to be there. Electronic medical records. Well, we call them EMRs, and we have a lot of other things we call them that we can't really say because they're a little bit crazy sometimes. Issues that are occurring within those EMRs are that they like to choose a code for the provider, and they're usually not accurate. And it's fine for a recommendation, but not as a mandated choice that the providers tend to use. Only the provider is to choose the level of service. The system itself is not supposed to do that, and many of them default over and have them do it. We can pick it up pretty fast when we start comparing these things. Fine for a recommendation, but not a mandated choice. Also, I found about 2 years ago systems that began to do something very interesting. It had the front desk demand The system was set up. To set up an appointment, you had to put in the code for what you thought was going to happen that day. Interesting. Then the provider would see the patient, and the front desk person was supposed to switch the code. They don't always switch the codes. So you have things getting billed out that didn't happen. And how does the front desk know what code you even put in? We have to watch it very, 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 very closely. And finally, we get to the claims themselves. And in the claims, we start to see all the things that really can make a big difference in how claims are adjudicated. Codes that are sometimes submitted by the practice don't match what was billed. And that's the question that has to come back to the billing company is how did that happen? Sometimes modifiers have been appended, sometimes things have been added, and we don't know why. We have to track those down. Fortunately for the buyer, in there, we find all of the NPI codes, the identification numbers, and the federal tax ID numbers. And the record that I have so far, there are 11 different taxpayer ID numbers in a transaction that was only supposed to have 3. So we can really dig those out and figure out what's going on with those. Those are my top 5. And later, if there's any questions and answers, I'll be happy to discuss them.
Great. Thank you, Dr. Troitlar. And now we're going to move over to John. Wait a minute. Who's going to talk about transactional diligence and how this differs.
Thanks, Leon, and thank you, Ty. So the term transaction diligence really translates to what's going to lead to a successful transaction for the foreseeable future. And what we really are talking about here is a total evaluation of whether the target has demonstrated a history of compliance and whether they can support ongoing compliance. So when we talk about what this means, we're talking about, does the target actually have a compliance policy or compliance guide, which represents what the billing responsibilities are, what all of the relatable guidelines are for the different payers, what the data is which supports historical claims, whether there's a process in place for concurrent and retrospective review, whether there's been an ongoing comparison of the claims that are actually submitted versus cash receipts, and finally, whether there's a verbal understanding of the coverage guidelines by the staff. So for each one of these items, these will give you an indicia of whether or not the target has a culture of compliance, an understanding of what they're supposed to have been doing, and whether or not you will have a successful transaction based on the underlying reimbursement data. Next slide, please.
Great. And then we're going to, the next slide, we're going to ask Bill to talk about the typical profit loss accounting diligence.
Yes, thank you, Leon. Typical PL accounting diligence involves analysis of the target's revenue and expenses. The objective of the analysis is to determine the accuracy and the sustainability of EBITDA and earnings. So this would typically involve analysis of contributions to revenue, and it would typically be broken out by payer class, and then broken out by service or item, and in appropriate situations, it would be broken out by physician. If there are one-time events, those would be analyzed for their impact. There would be review of material contracts and sales data. There would be testing of financial statements. But in addition, transactional claims and reimbursement diligence, as we've been emphasizing, is really critical to the healthcare transaction. Next slide, please.
Great. And so the question that this all leaves, I think you've heard sort of the high level of how this process would work. And now the question is, why does it matter? Why does reimbursement analysis, why is it the key to a successful transaction? So I'm going to ask in the following order, John, Bill, and Dr. Troitlar to comment on that topic.
Thanks, Leon. Absolutely. So the critical aspect of why reimbursement analysis is the driver, because it's the heart of the business and it's the heart of your compliance. If you're not having a successful history of reimbursement processes and you're not having a successful review of your reimbursement processes, it can lead to trouble down the road. And so the third-party payers, the relative importance of third-party payers within the healthcare cannot be overstated, because they are all going to be doing reviewing for purposes of recoupment, and they are a likely trigger. Typically, your issues with regard to compliance and FCA come from two sources. They are either disgruntled employees or they are your commercial payers, surprisingly, not your government payers. And the reason is that the insurers are very active in their underlying audits to see what they can recoup as a cost-saving measure. And to the extent that they identify issues with regard to your processes, they will send letters notifying you that they're going to be making recoupment processes. And it may be that if they feel that there's an ongoing issue, they may report you to a federal authority to the extent that you're participating in a federal program. With that, I will turn this over to Bill to continue on why reimbursement analysis is the key to successful transactions.
Well, thank you, John. I would emphasize that disallowances and overpayments can have a material impact on EBITDA and earnings, and these are always based on compliance with payer requirements. And for that reason, compliance with payer requirements in turn has a significant impact on EBITDA and earnings. So when you evaluate the transaction, you look at what's going to affect the sustainability of EBITDA and earnings, and you look at here compliance with payer requirements, because that's going to have the impact on the EBITDA and earnings on a go-forward basis. Also, there's the exposure to overpayment and false claims liability that we've been talking about. So with that, I would turn it over to Ty to give his observations.
Hello. We're going to be discussing payer mix, or sometimes referred to as payer index, and payer reports. The payer mix has a very interesting piece that it shares with all the documentation. It has to be producible. Sometimes we get stonewalled on that. It doesn't last long, but we have to get that report in order to see in the payer mix who's out there, who are the carriers that we're really looking at, because that then gives us the ability to start looking at known areas of potential concern, areas that they might be aggressive on, areas that they may want to look at, areas that we know are being audited at the current time. And to what's been discussed earlier, carriers are really a key to this, in looking at how they're handling their recovery of claims and their audits. The payer report itself is invaluable, because that's the guideline, the final piece that we can take a look at to really see what has happened with the different codes. It gives us the balance of the codes as far as what's the mix. We can see, for instance, what codes we expect in a given transaction and they're not there, what codes are present that we did not expect it. It helps us to give an idea then of where we should be looking and asking questions on these. And we can compare the mix of the codes to the benchmark from Medicare itself. Now, all practices, all areas are very different, and you can get some benchmark activity there to be able to know where you should be. And what we find often here is that a site may not know that a code exists, a new code exists that might be for bilateral. They no longer have to append a modifier, or they might not even know that a particular code exists. We've also bumped into the whole issue of the identification numbers and the issue around denial reimbursements. Now, the reimbursements are what they are usually during contracts, but maybe they're not being calculated correctly. The denials are very interesting because it lets us know how the practice is operating in regards to a denial. A denial doesn't mean it's not going to ever be paid. It usually means they didn't have enough information, or they didn't understand something, or they used the wrong code. Now, practice that you're looking at buying, are they responding, or are they putting it in a drawer? I was called to an orthopedic practice, and they were having a cash flow issue, $1.2 million of denials in a drawer that were never going to be touched. So these are all things that we look at to really take a look at those reports from the payers. That concludes my section.
Great. As we go into our next section, I want to just take a moment to share our CLE code. That is SS, as in Seyfarth Shaw, 1228. Once again, SS 1228. And so now we're going to really get into the specifics and details of how the process we have been discussing works, how to conduct a proper reimbursement analysis. And we're going to start with Bill, who is going to talk about the expected elements of a compliance guide.
Yes, thank you, Leon. Initially, from a high level, we would look at coding and documentation to conduct claims and reimbursement due diligence. So for coding of claims, we look at level of service in terms of intensity and severity. We look at whether preconditions for coverage are satisfied. Now, these are set forth in national coverage determinations and local coverage determinations in the case of Medicare, or in coverage requirements of the commercial payer. We look at whether indications in terms of patient condition are satisfied. These too are set forth in national coverage determinations or local coverage determinations in the case of Medicare, or in private insurer coverage requirements. In addition, we would take a deep look at claims documentation, and some of this Ty has touched on, but just to go over it, is the documentation producible at all? I've had situations where providers have not been able to produce documentation in support of the claims. Are the dates consistent? Are the services supported? Do they support the claim? Are the diagnoses reported in the claim supported by the documentation that underlies the claim? Is medical necessity supported by the documentation? Is the provider's signature present on the claim? Is it timely? Is it present, in the documentation, and is it timely? Next slide, please.
Thank you. And then we're going to ask to John to talk about the expectations for documentation.
Thanks, Leon, and thanks, Bill. So when we talk about the rules of the game for documentation, everything that Bill just covered are all required. And when we talk about payer guidelines, we have to have a clear understanding of what the obligations are for all purposes of documentation on both the government side and their commercial payers. And while the commercial payers typically have their own rules, they have been trending to conform with government guidelines under Medicare as a general rule. And to the extent that you are not in compliance with Medicare guidelines and policy, commercial payers will take a position that that's in breach of your provider agreement with them. So that's one thing to make sure that you have a clear understanding of. This would both be for historical data, again, trailing back probably to 7 years, and concurrent and prospective billing activity. With regard to coverage decisions, as Bill mentioned, you want to make sure that you have a clear understanding of what the local and national coverage decisions are. These are statements by, in some cases, region, and in some case at the national level for particular procedures and particular codes, and an explanation of why certain things are covered, or guidance as to how certain types of procedures or services should be billed in conjunction with other codes. And so it is again another guide that should be in your diligence file as you were collecting the documentation and conducting your due diligence. A third category would be your Medicare policy bulletins. Typically, if there are hot issues with regard to a particular type of procedure or service, there will be pronouncements by Medicare. This may be an ongoing issue where there are changes in the way in which the procedures are delivered, or changes in the way in which the services can be provided. Certainly, we saw a lot of this when there were changes with technology as we've gone to electronic service delivery, or where we had, for example, telemedicine. Any change to the way in which a service is delivered will likely have a corresponding policy bulletin associated with the particular code. And then finally, we can seek guidance from the Office of the Inspector General of HHS. They typically will have pronouncements for a particular industry. So, for example, if you're a hospital, there's hospital compliance guidance, and you should be absolutely sure to make sure that a copy of that compliance guidance is actually in the documentation of your target. If you are working on some sort of specialty pharma or specialty services, there is guidance for this, and you should make sure that the target has this in their possession and is in their diligence file. Again, this can apply to really any particular service, but the OIG has been very specific about including this and updating the industry on complex matters, which does dovetail with general guidance that they typically provide for the healthcare industry. Another resource that the Office of Inspector General provides is enforcement initiatives. On an annual basis, the OIG will tell you what their prospective targets are, whether it's behavioral health or whether it's the compound pharmacy industry. They'll tell you what they're seeing and where there are problems. And so the industry needs to pay attention to these things. These enforcement initiatives and their pronouncements should be part of the file that is included as you're conducting your diligence and collecting it. This should be part of the actual documentation that's included in the targets files. Next slide, please, Leon.
Great. So you hear, oh, actually, there's more here for John.
John, yeah, absolutely. So when we're talking about the compliance guidance, this means actually having a hard copy of this, or at least some reference to an electronic copy that can be located in a file. When we talk about the compliance guide or manual that Bill described earlier, this is actually a document that you would want to hand over to the government to the extent that the FBI, for example, shows up and they want to conduct an audit, or it may be a state Medicaid task force. You want to show the government that A, you have a clear understanding of what the rules are, B, that you're on top of what the rules are, and C, that you had the forethought to actually make sure that there's a process in place to ease their processes. Another thing that happens is as an audit is conducted, the government isn't as clean as we would like them to be, so it doesn't mean that once they go through your files, that the files will remain or that they'll be as organized as they were. So having something like this is a big push back to the government to let them know that you know what you're doing and they ought to be extra careful as they go through their processes. This is something that ought to be reviewed and updated annually. There ought to be a training module included in that documentation which describes the frequency of training for the staff, what the staff is actually trained on, and updates to any compliance guidance with regard to the specific procedures and services in your industry. The fact of training is also something that ought to be documented and signed by each staff member as they go through that process. So we're talking about a physical document. This is something that ideally should be in the file of whatever target you are actually going to be investing in or acquiring. And to the extent that you don't see something like this, it is a red flag, and you should be asking a lot of questions of the management team about how they account for this. This isn't the only way to approach this, but as a baseline, this is something that we would expect to see. Next slide, Leon.
Okay, now, and further on the conversation, what are we talking about when we're talking about lists of codes and necessary signature documentation? John.
So Leon, this would include not just the codes that you paid for, but what codes have actually been billed. You want to see a list of codes as by grouping to get some analysis, and you want to see some analysis on the codes that were actually billed. In addition to that, you want to see your signature documentation, which would include the parent or guardian for minors as appropriate, for the qualified professional, which may be the physician or some similar professional with the right credentials to perform that particular level of service. And to the extent that we're talking about procedures, which are either inpatient or outpatient, you want to see something that gives you an indicia of the in and out times or the start and stop times for each procedure each time that it is billed. And again, that may take electronic form or it may take hard copy form. Next slide, Leon.
And how about payer results? What are we talking about when we use that term?
So payer results would be a comparison of what is actually billed versus what is actually received in terms of codes by claim. You have to have an understanding, or each target has to have an understanding of how they're actually doing based on what they've submitted. If the target doesn't have an understanding of that, again, it's something that you need to speak with management about. And so there's a differential analysis between payment versus what the actual claim was. And along with that, there should be correspondence with payers to the extent that there is a recruitment notice and data to support what the outcome of that recruitment effort was. And the same thing with regard to the commercial carriers, there should be letters and or notices, and we want to make sure we understand what the outcome of those communications are. Thanks, Leon.
Thank you. So you, generally when we have these discussions, you'll hear a lot about the government payers, Medicare, Medicaid, but you've also heard alluded several times today the role that non-governmental players can pay. And so, Dr. Treutlar, I'd like to ask you to talk about a bit about the expectations in a review as far as what you would look at with payer mix and what payer reports you might be seeking from a company being reviewed.
So what we're really trying to look at is to see what actually happened with the claim, whether it was denied completely or paid in some way, and if the payment was made in some way, was it within in the context of the contract that the practice has with that payer. If it wasn't paid at all, then we need to go back and find out why that wasn't paid, and we can look at the policies and procedures. But John alluded to something else earlier with some of the local coverage and national coverage pieces, and we have bumped into this on several times, particularly with private payers, where they have taken and extrapolated different information, and they brought it over, and this is their policy based on the government information, when in fact, they only pulled over part of what the government said, part of a sentence. It's kind of like if you've ever raised children, they tell you part of the story. So under what they've written as their policy, they're not going to pay it, yet if they would have gone on a little further in the rest of the government policy, they should have paid it. So we're looking for those things at the same time, and then we also really come back to what the practice is doing with these type of denials. But those are the mix of those things, and in the middle of it, as I said earlier, we look closely then to see who is getting paid here. Where is the tax ID in all of this? And how does that all flow back into the practice?
And you know, why I would add that this matters, my work is primarily on the enforcement and investigation side of these types of cases, is that while you do have a pretty large federal infrastructure engaged in fraud fighting, you similarly have both a private sector fraud enforcement structure and a state-level fraud enforcement structure. So pretty much any state will have an insurance fraud division. They'll have an office in their Attorney General's office that will be focused specifically on private insurance fraud, especially for the very large payers like the Blues, who themselves play a significant role in the healthcare marketplace. So it really is important to be alert to these issues. John, I'm going to ask you in the next slide to talk about coding and payer guidelines and how that may play out in one of these reviews.
Yeah, one of the biggest issues that we've encountered in our transactional diligence for both investors and for purposes of acquisition is the fundamental guidelines regarding coding. And while there's typically similar codes for both government and commercial payment, there may be different approaches with regard to certain specialized services when we're talking about the use of bundling or unbundling, meaning the inclusion of multiple procedures in one code, or the use of modifiers, which would dictate a different level of service of the same service by a qualified professional versus somebody who's a technician, or the provision of a service or performance by a surgeon or physician versus a nurse practitioner. Those are the types of things that we need to pay particular attention to as you go through the coding analysis. And again, the local and national coverage decisions play into that, because there will be differences based on region as to how those things are actually tracked. And the reason relates to policy. It may be more expensive to deliver services in certain areas versus other areas, or the alternative is it may be that certain items and services are reimbursed at a much higher rate because they have to provide an incentive for certain qualified professionals to go into a region where there's a shortage. They call it a professional shortage area. The key to this is to make sure that whatever third-party coding processes and billing company that's being used by the target is software that is generally recognized, that's updated and consistent with both government, commercial, payer guidelines, as well as the national and local coverage decisions. We have often seen, and Ty and I have a very long history here, where we have seen that coding software is the culprit. So it may be that the target has done absolutely nothing wrong, and they're using third-party software, third-party providers to do all of their claims data, and lo and behold, we will see that the software itself is applying modifiers where they're not supposed to. And these produce anomalies, and these are areas where the government will create a red flag, and if this goes on for years, the government will show up at your door at some point. So sometimes the addition of the modifiers doesn't result in any increase in payment. So you need to have sophisticated counsel to make sure you understand what it means. But in many cases, it does result in a change of payment, either up or down. And so you have to make sure that there's a fundamental understanding by the target and the subsequent operating entity and management team that they know what their software is doing, that they know what their third parties are doing, and that it's consistent with current guidelines for coding processes. Next slide, please, Leon.
Okay, and Bill, we've already heard Dr. Troitlar talk about the fact that when he conducts a review, absolutely they must be conducted under attorney-client privilege. Can you talk about how the privilege interacts with the claims record review process?
Right, yes, thank you, Leon. It's absolutely necessary to conduct the review under attorney-client privilege so that the results are confidential. But we really have a process to evaluate all the claims data. It's not possible to do the claims data, to review each and every claim of a provider or a target So therefore, we do a process of statistical review, and that's where the third party comes in, which is an expert engaged under attorney-client privilege. And the third party expert, which was someone like Dr. Treutler, will do a probe sample, which will involve a random sample of 50 or 60 claims, and that will enable him to determine a full sample size at a given confidence level and precision interval. As an example, if we want to be 90% confident in the results of our study of claims to a plus or minus 4%, the probe sample will tell us how large the full sample that we have to study must be. The full sample is then analyzed. We use rat stats. We recommend this because it's used by the OIG and others, and it's generally accepted in the industry. That's a software that is a statistical software that determines the attribute error rate, and it enables us to convert that error rate in the claims to a financial error rate. The financial error rate is then extrapolated to the sample claims universe, and again, this requires an individual or firm with expertise in both statistics and medical review policy. This can yield quantitative information about the accuracy of past billings or accounts receivable or both. This has implications for both past and going forward EBITDA and earnings, and it also has implications for False Claims Act risk. There are significant False Claims Act actions that involve problems with claims. So the study of claims provides an opportunity regarding valuation of the transaction, and it also provides an opportunity to correct bad practices before closing. Leon?
Great, thank you. So we're going to talk about a couple of follow-up measures here, and I'm going to ask John first to talk about baseline documentation and procedures, and right after that, Bill to talk about representation and warranty insurance.
Thanks, Leon. So this is a real critical piece attendant to any investment or acquisition of a target. The issue here is you want to have a point in time where you know that the organization is acting in uniformity with compliance and that their protocols are in place, and so you don't have dates of services where items are in question. So to get a little bit more granular about that, what we mean is this. If you are conducting diligence, acquisition diligence, and you identify maybe the record, maybe before a company transitioned to electronic records, maybe they're using paper records, and perhaps there are dates of service where you don't have the documentation, or you're missing signatures, or there seems to be an inconsistency in who was delivering the service. Those will call into question the integrity of the data, and depending on how far back you go, it may be representative of past behavior. So as you're going through this process, what you want to try to do is identify a point in time, what we call a baseline, to make sure that it's at that point where you have your ducks in a row, you understand what's supposed to happen concurrently and prospectively, and you're certain that you have every rule, procedure, and policy in front of you and that's been implemented at a system-wide level. Once you've done that, you can say you have, your positive baseline documentation and that your procedures are in place. Once you do that, you're much better able to respond to either commercial payers or government payers, or to the extent that, there becomes an FCA question based on prior activity. At least you can point to the baseline and say, hey, we understand from our process that maybe there are highlights and lowlights to what was discovered through our due diligence. We're here to turn things around. We have identified that this is a point in time where we are certain that we're doing everything right. And we can't speak to everything that occurred in the past, but we've done everything we can to try to understand what happened before. There you're providing a very positive story, and it's a positive response to government that the new management in town is ready and proactive and, is attempting to at least have a good operating history. And you can't necessarily account for what happened before. You're not always going to have success or liability, but obviously we want to do everything we can to mitigate the damage of what happened in the past. Leon, I guess that concludes that piece.
Yep. And so, Bill, I'm going to ask you to talk about the role of representation and warranty insurance in these transactions.
Thank you, Leon. Yes, finally, we wanted to provide a brief note regarding rep and warranty insurance. As probably most of the folks on this call know, representation and warranty insurance is increasingly common in acquisitions. It basically operates by shifting the risk of noncompliance with the representation to the insurer and away from the parties. So presently, there are insurers who will write rep and warranty insurance without health care carve-outs, and this may even include coverage for defense costs and penalties. That's the good news. There's some information on the slide regarding limitations and deductibles. But healthcare billing in particular is often carved out of representation and warranty insurance. But our experience is that when there is reimbursement due diligence with statistical claims analysis, as described in this webinar, often claims risk can be included in rep and warranty insurance, and there can be the protection of rep and warranty insurance as an additional benefit of the claims due diligence that we've been talking about in this, and the reimbursement due diligence that we've been talking about in this seminar. Leon?
Great, thank you, Bill. And so I just, as we're coming to the top of the hour, or rather the bottom of the hour, just want to quickly identify a significant new area of False Claims Act risk. So you've had two significant pieces of stimulus legislation as a result of the coronavirus epidemic. One is the Paycheck Protection Program and Healthcare Enhancement Act, and the other is the Coronavirus Aid, Relief, and Economic Security Act. Both of these have given or have offered significant amounts of funding to healthcare entities that either have suffered economic loss as a result of the coronavirus epidemic or who have had to take on additional burdens in the process of fighting the coronavirus epidemic. And I've cited here actually to an alert that Bill posted in our firm's News and Insights that describes the scope and nature of these protections. But these funding provisions have come alongside of significant anti-fraud provisions about which receiving providers should be aware. And so if you look at the Department of Health and Human Services Office of the Inspector General Work Plan for May 2020, you can see that they have signaled a concentrated focus for 2020 on this stimulus legislation and possible fraud arising out of the use of those funds. And $570 billion in the amount of news and focus that there's been about this area turns it into the kind of shiny object that both private whistleblowers and government enforcers are going to be paying attention. And so you see here goal 2 of the Department of HHS OIG's 2020 work plan talks in considerable detail about the kinds of audits and review that they are going to be expecting to do into the False Claims Act. What you've just observed is evidence that you should not be the moderator and speaker at exactly the same time. I was doing fine until I actually opened my own mouth, so sorry about that. So I think I'm not sure if we have questions, but I'm going to tell our support that yes, indeed, please put us into an environment where just in case we can have some questions asked if they are out there. Let me once again, by the way, just repeat our continuing legal education code. and that is SS1228. Again, SS as in Seyfarth Shaw, 1228. Okay, it actually appears that there are not questions today. I think you have contact information for all four of us. So if you do have questions after today, please feel free to send either of us a note or give us a call, and we will try to help you as best we can. So thank you all for joining with us today. We hope you found this useful. Thank you, Bill, John, and especially our special guest, Dr. Troitlar. It's really been a pleasure co-presenting with you this afternoon. And everybody have a great day and a great summer. Thank you.